Move right on to the next session that we have. From all of the messages that we've heard thus far, the experiences, I was sharing with a colleague earlier this morning a story that someone had shared about Wayne Gretzky. How did he become the goal-winning hockey player? And one final analysis that he gave was he always skated to where he thought the puck was going to be, not where it actually was. And so what we've heard today causes us to really hit the goal as we move in the direction of where we think the movement is, not necessarily where we are right now, but moving in the direction of where we anticipate the growth to be. Having said that, that leads right into our next session here. There are two panelists, two presenters that we have that you'll hear a lot of really strong information, applicable information that you can take back and share to your health centers. First, we have Sam Little, who is the founding president of the National Alliance of Resident Services in Affordable Assisted Housing, NARSA. He has held positions in the field of employment, public housing, research, and human services, combined with university teaching and consulting. He currently serves as the assistant dean for field education at the School of Social Work at the University of Maryland, where he earned his PhD in social work years earlier. And I must say that I have had the privileged opportunity to attend NARSA's conferences and of residents, and it really seals the relationship that we as healthcare providers have with the residents of public housing. So I want to say publicly thank you, Sam, for founding such a wonderful initiative. Next, we have Marianne Chisum-McGill, who is the Director of Programs at TCA Health. She has well over 20 years experience in working with community-based organizations to create, build, manage, and sustain and expand support programs for public housing and low-income families and individuals. Her role at TCA Health involves overseeing WIC, Healthy Start, SNAP, and the Health Wellness Collaborative, and the Public Housing Primary Care Program. And as Marianne may be new to the movement with public housing primary care programs, hearing from Veronica, she's well seasoned and understands the mission. So we welcome and like to hear what you have to say. Next, Sam.
Good morning to everyone. It's a delight to be here today, and in the interest of time, I'm going to deviate from what I planned to say and want to sort of emphasize about 7 points that I think have to do with engagement of resident leaders and the broader community in the work that we do in these important centers. Let's begin with this thought that, first of all, engagement is a process that connects at least two entities. Got to have two things, at least, to be connected. And in this instance, it's the resident leadership of public and sometimes assisted housing communities and the broader health delivery system or the health services network. It's sort of a marriage ceremony that seals this relationship. And I know there are many of you out there who are married, so you can remember the happy days of the marriage ceremony. But it is also a sort of an affinity, a relationship that is built between two entities that make for success in accomplishing the larger agenda that centers are set to accomplish. And the agenda obviously can be very awesome. Just about 7 points I want to make briefly that I think have to do with how well engagement takes place, how we improve upon it, and how it can be used as a tool to help centers to be very effective in the awesome work that they undertake. There's this thing that I refer to as the web of entanglement, and it's our resident leaders and other stakeholders out there in the broader community who are frequently faced with the threats to longevity and well-being, health disparities, environmental hazards, social cancers out in the neighborhoods, and all the other things that you are the experts on, many of you are the experts on. So this web of entanglement, and the importance of engagement is that it soothes a release of those conditions of the entanglement that tends to keep people segregated, fragmented, and uninvolved in the life and the welfare of their community, in particular when they can impact the well-being of individuals and of the entire family. As a part of the whole process too, the second point is resident leaders are viewed as consumers who should be at the table. The process is a collaborative one, and the consumer ought to be a stakeholder who is at the table. And in the process of doing so, a spirit of engagement requires that the consumer actually participate in the planning and designing of interventions that have to do with improving the quality of life for individuals and families. All of this is rather basic, and it's not rocket science. And one of the reasons I'm deviating is that I think some engagement principles and a framework is exactly what is needed often to keep the relationship a strong one, and where the marriage ceremony hasn't occurred, it indeed can occur. A third point is engagement really has to do with capacity building and leadership development. There's tremendous capacity in the rank and file of leaders, of lay leaders within resident associations and councils, et cetera. And we have to find ways to attract younger leaders and pass the leadership and capacity building baton to others so that the movement does not stop and leadership development does not stop, that it continues to grow and to build. Resident leaders are really the ground troops in the community. And in any war, you need ground troops. It's okay to have the ballistic missiles and the airplanes, but you have to have seasoned, well-trained ground troops that work in tandem with the other component parts to win the war. And the war in this instance is improved health and wellness of families across the scene of public housing, not, quite frankly, only in the cities in which existing centers are, but in other cities across these United States of America where health disparity is that entity that reduces longevity, reduces life, and is something that we all are committed to improving. Just a few other points. An enhanced mindset about the care of the body. As we face a growing new generation that needs to be empowered, we can't overemphasize the importance of helping to create a mindset that this thing called the human body is just magnificent, and it's incredible entity, phenomenon, matter, object, whatever you want to call it. And what we put in it, how we take care of it, how we treat it, has to do with attitudes and beliefs about it. And the more we can do in the engagement process to help both current leaders, but a succeeding cohort of leaders to appreciate and value and take very serious the care of the body, the treatment of the body, and become the fanfare club for ensuring that the mindset toward the body is improved. Empowerment to promote health evidence-based programs. intelligence, the use of data, the use of information, the use of reports, the use of relationships by the ground troops that can be those who help to promote and to inspire others to become part of the larger network or the service delivery system that centers aim to bring into the workings of the local center. So we can't overemphasize. In fact, if there's a criticism, we don't significantly or adequately emphasize the importance of empowerment of leaders to equip them with the tools, with the knowledge, with the interest, with the motivation to be drum majors and drum majorettes in the larger community to advance what centers are trying to do. And two final points: partnering or partnerships with the health centers. Something I often refer to is called empowerment projects, passion projects. The creation of passion projects, a project that a local leader has at heart, that it likes to do, that its way of relating to others, to convincing others, to engaging others in the broader community in something that is important for the overall well-being of the community. So the creation of empowerment projects and of passion projects as a strategy to do more engagement. And just as a sidebar, NARSA takes great delight in having created about 100 passion projects now that resident councils use to engage families, to excite people to change, to become involved in responsible social action engagement when the bottom line and the byproduct is to improve the health and well-being of families in the community. And then the last simple point that we often hear that cannot also be overemphasized is the relationship between engagement and advocacy and public policy influence. Advocates, ground troops are advocates, and advocates have to be adequately trained and need the tools and the resources to do advocacy work, and can be a thunderstorm of energy and help to centers to carry out the larger mission. And public policy and new legislation and regulations that do not focus on what I would say would be a healthier future for families in general, some balance or equity in the way health care and health resources are provided and disseminated within communities that we work within, sensitivity to the culture of the different groups and populations that we work with, and respect for individual differences and appreciation for the unique experiences that individuals bring to our doorsteps. And then finally, I can't see my notes in the dark here, but there's a point I want to make that has to do with a genuine investment in families. We cannot move away from an emphasis on the investment in families. Strong families, as you would believe and know, make for a strong city, a strong city, a strong state, strong states, a strong nation. So there's this dotted line of a need to emphasize an investment in families. And in the process of that advocacy, resident leaders can do it with bodaciously, very bold, very outpouring in efforts and in strategies. So social engagement is that marriage ceremony that seals relationships and makes it so important that people who are the consumers are at the table and are engaged in all that is planned to uplift communities, to strengthen families, and to make the communities that centers are located in better places to live. I believe it can be done. These points are lessons learned from around the country and are the voices, quite frankly, of leaders and their mentors. So I offer them as points for consideration as a way of improving and enlarging the concept of engagement that centers undertake with the very important resident leaders who are in the communities in which you work. It's a delight to be with you this morning.
Good morning. I'm going to ask that we see a little video. I hope it comes out clear. I'm not certain, but I didn't bring Leslie with me, but I needed Leslie to speak to you.
And it's over 4,000 people in the community, and I feel that it's a necessary thing. We need health care because you don't never know when something is wrong with you. And some people haven't had insurance for over 10, 20 years. Now we have them enrolled, and I think it's a good thing. They are very proud, and I'm proud as well. Thank you.
Leslie is someone who works for TCA Health, and she's a public housing resident. She also is a CAC certified application counselor, and we're proud to have her on our team. I want to say, Dr. Little, you talked about a marriage, so I want to share the marriage that we have with our public housing authority in Chicago. Talk a little bit about outreach and our patient engagement as well. I want to first open up and tell you that we're doing great things in the city of Chicago on the far south side. We have done much, but much still needs to be done. Prior to the Affordable Care Act, TCA was faced with many of the same challenges that many of the other health centers have been facing. What made TCA's challenge uniquely different is that we are housed within the public housing development. When I say in the development, we are part of that community, part of that neighborhood. The community is occupied by about 1,300 public housing families, which is about 4,000 people. We're surrounded by other neighboring low-income housing communities as well. It's about 3 other communities. The community is isolated and very limited to commercial and shopping areas or public transportation. It's impacted by a land of sewage treatment plants and a large forest preserve of open land. The community is 97% African American, and its population is young people. 50% of residents are ages 24 or younger. Its population is young people. 60% of the population lives below the federal poverty level. They're impacted by childhood obesity, asthma, diabetes, a lot of heart diseases. So on one hand, the ACA was an opportunity for this community, but on the other hand, it was a threat, and it was also a challenge for TCA Health. Many of the residents felt that it was issues with the ACA, so we spent a lot of time going into the community, talking about it, sharing about what changes were going to come for the residents. Many of the residents felt that they were not trusting of the system, or opportunities being offered they weren't really interested in. We were really faced with limited outreach staff to support with the education and enrollment for this large number of public housing residents and those neighboring communities as well. Yet, we still needed to support and guide the residents through the ACA and how this would impact their lives. These were just a few of our external challenges, or perhaps the hardest ones. Internally, within the clinic, we were faced with the challenges as well of trying to figure out how are we going to manage this, get this information to our team inside, to the medical staff, so that they also could be part of the learning process for patients that were coming in that were public housing residents. So we needed to actually train our staff and prepare them. We also needed our staff to use every encounter as a time to answer questions and to dialogue with patients about what was going on, or at least to redirect them to some place that could offer them help or assistance. So to address both our internal and external challenges, we comprised a patient satisfaction committee and an encounter improvement committee. Two of the major campaigns that was adopted by these committees, one was our Yes campaign. As a staff, we made a commitment to say yes with conditions to our patients and those that encountered our doors. We also felt that this was a means for us to be proactive in our role with our patients, and also to be able to provide quality care from the time they enter the center, the medical center, and when they exit the center. The second campaign was for us to make a commitment to be a good neighbor to the community of public housing residents. Being a good neighbor meant building trust that we could work together in the best interest of our community by being a vested partner to our patients' health and the community in which we serve. To better build and strengthen our relationship with the community, TCA Health took on an active role as a vested partner in the community and with the Chicago Housing Authority, the local advisory council, and the property management, also with other organizations that were surrounded in the community. There's actually 31 community partners that actually support the Alt-Gale community in Chicago. Most importantly, we made a conscious decision to use our HRSA outreach and enrollment funding to hire public housing residents to work side by side with TCA to conduct outreach and enrollment for the ACA. This meant that we had to change some of the way we do business and also look at some of our hiring practices. Prior to selecting the public housing residents, we solicited a team of staff. We also solicited the support of Chicago Housing Authority and our local advisory council to recommend who they thought would be a good fit for being a part of this ACA. We also revised the job description to truly reflect what was needed on our outreach team. Some of the key language we used was a committed resident, someone who was respected and trusted by the community, someone who demonstrated a track record, actively involved in the community, served as an advocate for people, and willing to educate the community about the opportunities available around healthcare coverage. From these efforts, we now have a dynamic team of outreach staff who are certified application counselors and trained county care assisters. They are all proficient in everything that they do, and they can now navigate the healthcare system that they are now part of. All were uninsured. The whole team of outreach staff that we brought on board, all were uncovered, some for 5 years, some for 10 or 15 years. Now they're insured. Every Tuesday morning, this team gets up, they come to the clinic, and at 8:30, we meet, we conduct a brainstorming session on how we're gonna touch lives and change lives in the public housing community. Our philosophy is that a good place for enrollment or education is where there's more than one that gathers at a time. Some of the places that they have conducted enrollment have been the local library, barbershop, property management office during the week for rent. They also enroll at the liquor store, the laundromat, the high school lunchrooms, all community events, and they huddle just to brainstorm on new ideas. So we do this on a regular basis. We also look at ways on how we can visit, if need be, the homebound or people that are shut in. We also look at ways of engaging our patients that are in our waiting room. So they spend time in the waiting room, and they also participate in the morning huddles with the patient services team to talk about who's coming into the clinic that's not covered by health coverage. So we are really creative at engaging the community. Another opportunity we used was that we identified the organizations that were in the development who might have staff on board who would come into day-to-day contact with public housing residents. And through these efforts, we were able to educate 44 housing case managers on staff at a program in Chicago about the ACA and how this would impact public housing residents and how they could best support us in educating the residents and getting them signed up for coverage. What makes this team phenomenal is that not just because they're part of TCA, it's because they believe in the work that we're doing. They also are just an example of the great outcomes that you can achieve when you really do buy into public housing residents. And what I mean by that is that we took a team of staff from public housing and we vested our time in making sure. Did we have challenges? Of course we did. One of the challenges we had is that we weren't certain if some of the residents would be able to pass the state and the federal test. But guess what? We hired tutors for them, got volunteer tutors for them to help them understand the testing system. And so they were very successful at doing that. We also felt it was important because they're able to speak about their personal experiences and challenges with navigating the health system. And they also were able to provide a lot of insight for us. The benefits in having this type of marriage is that it produces a win-win for the health center and as well as for the community. Because of the partnerships like Chicago Housing Authority and the Community Health Partners for Sustainability and 4 other agencies that work with us at a work group through Chicago Housing Authority, we were very successful. We actually had 4 other FQHCs on board, which was Access Community Health, it was TCA, University of Illinois Miles Square, and Heartland Human Care Services. And we collaborated to host a Get Covered Illinois booth at a Chicago Housing Service Fair. At that event, approximately 5,000 residents attended across from the city of Chicago. Staff from every health center collectively talked with 527 people, and about half, 249, filled out REF cards, request for information cards. We followed up, assigned each group of folks by zip codes, and was able to actually successfully outreach to those folks to sign them up for healthcare coverage. Another initiative, and I'm going to be quick, that was headed up by the Chicago Housing Authority, is that they actually work with an organization that actually gave funding to the Chicago Central Advisory Council. And they work with all of the FQHCs to host activities throughout for over a 3-month period during the months of November, December, and January. And so we work very closely. We have an awesome relationship with the Chicago Housing Authority, and because of these initiatives, we're able to be successful in some of our efforts. What's next for TCA Health? Well, our CEO, Veronica Clark, would say, good job, but we are not where we need to be, but we're almost there. So keep up the hard work. As a team at TCA Health, we know that it's time to dig deeper with outreach and enrollment and take our efforts to another level. We are looking at ways to support those that we have not been able to touch. Most of them are the young people, those with illiteracy issues, those who are homebound because of physical health challenges or mental health challenges, or those that are just fearful of the system. And then there's also a lot of people who we know that are men that are still uninsured. We're also looking at ways to offer specialized services for those needing to renew, those that have no understanding of how to utilize their benefits, those who have received denial letters and have put them in the garbage, those who have no understanding of how to move forward to face an appeal or an exemption, those that are still not understanding the coverage and using it the way and are using it the way we use our car insurance for emergency accidents only, and those that don't know the first thing about finding a provider, as well as following up with the newly enrolled on their status with coverage. And what I want to leave you with is that it is your responsibility as a FQHC and as a housing authority to be a vested partner and to be a good neighbor to the public housing residents or those that you serve. Thank you.
Thank you. I'm just so amazed at the depth of information and experiences our panelists have shared this morning. Having grown up in the South, used to stories that kind of depict a message. And as both panelists were speaking today, a couple of things that struck me were outreach, empowerment, training others to take the place. And it made me think about if any of you have ever seen geese as they fly in a V-shaped pattern, where there's one at the front end that's breaking the air so that the others can go along, but that person is really the one that's pushing forward and the others are coming along. but then they fly about 400 to 500 miles a day. So when that front gets tired, they revert to the back, and then someone else takes the lead. And as I think about that and how it relates to outreach, we often have to continue, I think, as you said, on the ground, making it happen. So there are those that are there, that are challenging, that are pushing forth, but as they get tired, then someone else needs to come in and take the place so that we can continue this movement, continue the outreach. I think we heard earlier there are 8 million that have been enrolled and now have health insurance, and maybe for the first time. I know there was someone that I'm dear to that had health insurance for the very first time. So then as we continue this plight of outreach and enrollment and engaging with our residents, just think about the little story of the geese, how they fly in a pattern 400 to 500 miles a day. That we too can continue on this outreach, this movement, this struggle. I think we do have just a little bit of time as we thank our presenters for some question and answers for a few minutes. So I know there are a couple of mics somewhere in the room that if you have a loud voice, like I do most times, feel free to acknowledge your question and answer that we can direct to Dr. Little and Ms. Chisum-McGill. Anything else? I know today has just been packed, so we're kind of taking it all, soaking it all in. Yes, please.
Question for Marianne. What kind of barriers did your staff face when it came to knowledge of the people that they live with, as far as like their peers?
You know, it's a couple of things. Can you hear me?
I can hear you.
There's a couple of things that we did internally and externally. One thing that we did approximately 2 years ago, we did a focus group with public housing residents to identify what some of the barriers were that were preventing them from coming to the health center. And so we made that part of our plan to put in place. And we also did internal surveys with our employees to talk about what are some of the issues that are preventing them. A lot of people just don't know. And I think with the ACA, one of the things that made it clear to us is that it was important for us to talk about. Actually, there was a presentation posted on the HRSA website or either CMS, and it was a presentation at the early beginning of ACA, and it talked about talking about to the providers and to your staff about how do you engage public housing residents and preparing them for the ACA. And I think it was one of the best presentations that we did. And that's something that our CEO supported, is that we had in-service training. We trained all of our staff about what to expect, what kind of information you should be sharing with the residents when they come in. So we made them part of the process. We didn't just do it as an outreach team, it was an entire process. And another thing that we did that was really different is that we had open sessions throughout the week where people could come in. We would have doctors, we would have outreach staff, residents that would sit in a forum, and we would talk about the ACA. So there were questions that doctors had that maybe they couldn't get from their colleagues, but they can get at that table from the CACs. We could answer some of their questions. And then some of the patients could hear some of the questions that the doctors were asking, as well as patients could hear, vice versa. So, I mean, it was a learning process for us. So I think you have to just be open-minded and be willing to make everybody a part of the process.
Mm-hmm. Yes, please.
I'm not that soft-spoken, but I'll use the mic anyway. I absolutely applaud you for engaging uninsured residents to become CACs and assisters to then reach out to others. I think that's a wonderful model, and I intend to use it. I think it's fabulous.
Awesome.
But here's one of my concerns. How are they paid? And what's the strategy for sustaining employment for those who obviously were probably low income coming into this process? Now they're all psyched and engaged and working and feeling empowered. What happens to them in terms of employment, and how do you fund that initiative?
Well, the FQHCs were given additional dollars for outreach and enrollment. And so we use those dollars to support our residents being CACs. And our goal is to sustain that. We actually are submitting for additional dollars as we speak. We're writing a grant as of now. And so we think that they're a necessity for the community. And I encourage all organizations, you know, that's one of the things when I came there, Ms. Clark actually had a team of folks who actually have been vested in the community. TCA has been around for over 40 years. We have patient service staff, so there's a seasoned staff who have been there, but we needed to bring some new blood into the clinic. And so we use our enrollment dollars through HRSA to hire public housing residents. And hopefully HRSA will continue those dollars because it's really a critical component to the FQHC. So I would just encourage you to do that and to look at any additional funding that's coming down to support that model.
Yeah, one of the follow-up pieces to that is we're considering training them also to become community health workers.
Yes. Awesome.
So as we expand that role beyond just insurance, but also helping people with the other social determinants, that perhaps when the reimbursement opportunity comes to the state through the new CMS rule, there may be a way to sustain them. So I was just wondering how you were doing it, because I think we're all on the same page that while we have the money, we'll do it this way for now.
Yes.
But how do we sustain those people, because it really is a workforce development strategy.
Exactly, I agree.
Yes, please.
Hello, my name is April Simpson. I happen to be the Resident Association President of the largest housing development in the country, Queensbridge Houses. And a lot of our challenges is of what you both spoke of. Dr. Little, I really admire you. I was at the Nassau last year, and I was floored by all the information that I gained from just attending that conference. And I appreciate, like the lady said, I'm gonna move forward in that strategy of using our residents to help the other residents. But there's some difficulty because you have resistant residents as well. I'm just employing everybody to partnership. I love what you said about the marriage, the engagement, Dr. Little, and it's so true. And what I'm finding, being first a resident of the community before any type of leadership, and I thank you for saying we are the ground troops, because anybody that know me at this table know I go running. I need roller skates for my community. I have learned that in partnering with other resources, we become a more viable and more resourceful to the resident and to the community as a whole. So I'm employing anyone that's here to outreach with your resident leader councils and the partnership with the health centers, like I have Cynthia Davis from the Floating Hospital, that's right there within the community, right there, smack dab in the middle of Queensbridge Houses. And it's like, it's a breath of fresh air to know that you're not alone. And a lot of times, sometimes we feel alone when we're trying to engage our residents into, you know, providing them with health care to come on. Because still, even with the ACA, there are a lot of residents, and I'm from New York, that are young people in the 20s, between 20 and 30 years of age, who are working, but they don't make enough money to still afford affordable care. And that's what my next dilemma is. But I know that we're gonna persevere because we're gonna keep on pushing. Thank you.
I want to just add that I want to not leave out, before we hired the public housing residents, we received recommendations from Chicago Housing Authority. I have to give Andy Titleman, who works, he's part of the marriage. He's married to TCA Health through the Chicago Housing Authority. And we also got an endorsement from the local advisory council. And when I said those terms, I wasn't just making those up. We needed people who were committed. We needed people who the community respected as trustworthy. We needed an endorsement. We did not need anyone to join our team that was battling with the community. And so we took recommendations from the Chicago Housing Authority, because as I said, it's 4,000 people in the development. And we needed those recommendations from the local advisory council president. Is this someone you support? And they gave them 10s for everyone that we selected. And so it was a partnership. It wasn't someone, we posted a position, specifically for public housing, but we took word of mouth from Chicago Housing Authority to give our recommendations in the LAC, Local Advisory Council.
Okay. Yes, question there.
I might not need this. Good morning. My name is Eugenia Smith, and I'm from Boston, Massachusetts. Geiger Gibson, First Health Care Center, one of the two. But I'm here, and I basically want to say to all of us, the attendees here, to listen to what you hear today and to take it back. Don't sit, answer your emails. There are a lot of people, I'm sure, that would have liked to have been here, and if you really, this wasn't really your thing, learn to pass those bucks on to someone who can benefit by this information. Another point I want to make is that public housing residents are residents. They are people. They are not a public housing thing. They are the same as you. Their address is different. They have the same health needs and concerns that you have. It's just that they lack access to get them. They lack layman terms to understand the condition in which they live. So when you say about sustainability, what we need to be doing is we need to be partnershiping with the universities. We need a partnership with the health commissions. In Massachusetts, the Boston Housing Authority, we have a partnership with the Boston Public Health Commission, Boston University, and the Community Committee for Health Promotion. I am the chairperson of the Community Committee for Health Promotion. We work together so that when there are health issues that need to be addressed, we have the whole community at the table. So when you talk about sustainability, and we say, we want to train health advocates, we want to train navigators. Okay, so we bring in 10 to 12, we train them, and we say, okay, we've got this one-year contract, we'll hire you for 1 year. While you're doing that, while you thought about this navigating or community health worker idea that you were thinking about, always keep in mind, where are the other provisions or providers that need these same healthcare workers? We took our navigators and we turned them over to the School of Dentistry. They were looking for healthcare workers. Always keep your ear to the ground. Know who's looking for those that you are training. Be engaged, become a partner with them. So when they get those bucks and they get those contractors that say, we need community engagement, I got it, I'm here. We got 2 workers right here, trained, ready to go. That's where your sustainability comes in from. Have a resource that is up and ready to go, which also means you have to stay engaged with that community that you trained. So we have health workers, and we keep track of them. We monitor them. We have a 5-year record. We've been doing this for 12 years. Our health navigators are still in place. We just did an event this Saturday, which was called Bridging the Gap, which means that we have to bridge the gap. We can't step over each other and say, well, I don't understand you, so I'm moving on. You can't expect a public housing resident to understand chemotherapy. You need to explain to them about cancer. A lot of residents will tell you, and people in general will tell you, okay, I have cancer. Guess what? I'm going to die. And when I hear that, I say, yeah, but how do you want to live today? Because you're not dying today. How do you want to live tomorrow? We have to get them involved at that level to say, it's not about the health of you, it's how do you want to live until that day comes. And we have to have those provisions, those health care centers to explain and to be willing to be a part of that community engagement that says, I'm going to send you a flyer to your community, but I'm going to make sure that you understand what that flyer says. And the first person I want you to talk to is not come to the health center. I want you to talk to your neighbor next door and say, I just found out that we have 30% a higher rate of asthma in our development. Did you know that? The cancer rate here is this percentage. Did you know that? I want you to talk to your neighbor first, because that's the one who's around you. That's the one who's going to say, well, let's talk about this together. How do we ask the questions? There's no one there to tell them how to ask the question to the doctors. We need to get things back to residents in layman's terms so they feel comfortable asking the question. I have diabetes. Okay, so why shouldn't I eat that? Are you going to buy my groceries? Because I can't afford not to eat that. So we have to have a plan. We just can't tell people they're in bad health and say, okay, go home, you know you have this disease now, and fend for yourself. We have to teach them that, okay, this is your budget. We all know that fruits and vegetables. We also know what the price of fruits and vegetables cost, but we also know that there's this aisle that says $1 for cookies, $1 for candy, $1 for snacks, $1 for this, that has just wrapping papers. When you give children fruit and vegetables, you're dealing with skins, you're dealing with seeds. It's a lot easier to clean up a paper bag from a bag of chips than it is to go around picking up orange peelings, corn from apples. These are the things that we have to get back in when we start talking about health and healthiness and wellness. We have to put that whole package together. We have to realize and understand what that means. Don't just give someone their condition. Give them the tools to live with the condition.
Thank you. Thank you so much for all of the questions for our panelists. I think you'll be around for the rest of the day, and please engage them with any other questions or comments that you may have. To keep us timely, somewhat on track of time, we're going to conclude this session as we prepare for the next.
So yeah, and I've just been informed, please, again, make your way out to the breakout rooms. Before you do that, please do complete both evaluations, both for the first plenary on policy that Teen hosted, and of course for this great panel. I'm led to understand that the cream-colored sheet that you have is for the first plenary on policy, and that the stark white plain sheet is for this panel right here. So you can make your way to your breakout rooms, but first, another great round of applause for our wonderful speakers.